I'm Andrew, one of the health influencing senior officers and early diagnosis lead. I'm not a clinician. My background is in science, policy development, so I won't be able to answer any clinical questions for that reason. But I can do my best with answering questions on any other aspects of this work. Moving on to my next slide. So just in terms of the stuff I'm going to cover, so quickly run through the PSA consensus, and then talk a little bit about how that PSA consensus is being used in our other work around screening and current evidence for screening, around how we talk about the diagnostic pathway and the changes to that pathway, our approaches to informed choice, and then our wider approaches to awareness and addressing inequalities. So the PSA consensus was ultimately driven by the lack of a national organised screening programme for prostate cancer, and the fact that the current opportunistic testing guidelines are dangerously outdated. So we undertook a consensus on the best use of the PSA blood test in asymptomatic men. I led that project, so that resulted in the latest consensus. And in terms of how this has progressed our work in the sort of earlier diagnosis stages and consensus statements and recommendations, and how they're being used throughout all of our awareness work, our political and health systems influencing, and our healthcare professional education as well. So it is a research paper. It is aimed towards clinicians, but we've used a lot of the recommendations and messages and results of the consensus across all of our work as well. So we worked with 15 clinicians and researchers to get to our consensus. We published this paper last year in the BJGP, so that's the British Journal of General Practice. So that's the audience we were primarily trying to get in front of. So primary care, that's the interaction where men see awareness, messaging, understand their risk, want to have a PSA test and go to their GP to have that discussion. So it's really important, a big win really in terms of getting our paper into that journal and getting that in front of the right audience. In addition to that, we've presented this research to over 1,000 or thousands of GPs since, and that's through conferences, webinars, and a podcast as well. So again, really not just producing research and the evidence, but really pushing it out there. And when that paper was published as well, we launched that through a big media moment as well, led by our comms team. More recently, the paper was announced as their third most read paper in 2024. So people are reading it, people are looking at it, and people are sort of taking away the recommendations from that paper. And it gave us another opportunity to promote that as well amongst the clinical community. So this is just a brief list of some of the consensus statements, but probably some of the most important ones. In terms of awareness, there was agreement that there should be awareness raised amongst men aged 50 and over, and in men 45 and over who are higher than average risk. So that's Black men and men with a family history. And in terms of awareness, that is shared amongst not just charities, but also the NHS, governments and public health bodies. So it's not just us sort of banging the drum for it. It should be a collaboration in that sense. Proactive discussions, and this is the biggest deviation from current guidelines, is that what the consensus said is that there should be proactive discussion for higher than average risk men. So GPs, healthcare professionals should be having a bit more proactive approach to discussing prostate cancer risk and the PSA test in those groups. Importantly, PSA tests for all informed men should remain from the age of 50. So we're not saying just drill it down to highest risk men. It should continue to be accessed for all men. Again, importance around providing balanced and balanced information, so around the pros and cons of the PSA test. So men need to understand how those pros and cons of testing work for them in their individual circumstance. No need for a DRE if PSA levels are above the referral threshold. And then another important one is the acknowledgement that resources in primary care should be there, for primary care to properly deliver that current policy. And that includes stuff around education and access to the PSA test, or conversations about PSA testing via trained healthcare professionals, not just the GP. So I'll include some of those consensus statements again throughout the rest of my slides where relevant, just to sort of bring that in and share where that's sort of being used in our work. I'll touch briefly on screening, but just conscious that our director Chiara provided an update on this at the previous session, and our sort of position and planning around this. So yeah, if you missed that session, go back and have a listen to what Chiara said. It is sort of a throughout the last six or so months, and probably going forwards until we get an announcement from the NSC, there's a bit of a shifting platform, but we'll aim to sort of keep abreast of that and keep ourselves up to speed on what's happening with that as it happens. So there's just a recap on what screening aims to do. So screening is about identifying healthy people with an increased risk of a disease or condition. And screening is always about personal informed choice. So it's about that balanced evidence-based information on the benefits and risks of screening. And that should be provided for all instances of screening and testing. And it's important to say that there's no perfect screening test. Screening is about using a test, but reducing and minimizing the harms from that test throughout the pathway. I'll just go to a little bit more detail on those words that were highlighted on the last slide. So screening should do more good. And that's the big question here, is whether an intervention such as the PSA test or the PSA test plus MRI saves lives through screening. That's one of the big questions. In terms of harm, we want to reduce harm, and that includes things like overdiagnosis of cancers that wouldn't have ever caused harm in a man's lifetime, potential over-testing, so for those men on surveillance, potentially undergoing regular PSA, MRI and biopsy, and then the over-treatment of these non-lethal cancers and the side effects of those, so incontinence and erectile dysfunction. There's also this thing about reasonable cost. So any screening intervention must be delivered at a lower cost than no intervention. So all those three things are things that the UK National Screening Committee have to consider. So at the moment, this is as of November 2020, based on the evidence that they looked at that point, they don't recommend screening. So they say issues still around false positives and false negatives, and that the evidence didn't demonstrate that PSA screening could save lives. And that's important to note that that's PSA screening, not PSA plus MRI or PSA plus another test. So all these decisions are based purely on PSA alone. So the current position is, again, this is something that some of you might have heard Chiara update on. So back in 2022, there was an annual call for screening proposals, and there were around six submissions for that in terms of prostate cancer, and that covered targeted genetic testing, all men, and things like that. So different iterations. But the NSC are looking at all of those different things, looking at the evidence, looking at the health economic modelling aspect of it, and then addressing any evidence gaps. When it comes to addressing evidence gaps, we're sort of part of that as an organisation leading in this field. We've looked at previous reviews, previous evidence gaps, and said, well, how can we plug these gaps? How can we address this ourselves and try and move things forward and progress that? So again, yeah, we sort of expect an update this year alongside a consultation. We don't know when that might be, but again, it's something that it's an active thing that we constantly review and update ourselves in terms of our insights on what's happening with that. So at the moment, consensus statement on that is that there's no national screening program, so men don't get invited, but men at risk who have discussed the harms and benefits of the PSA test have a right to that test from a trained health professional if they want one. So irrespective of whether there's a screening program, we need to have access for men who know they're at risk, who know the harms and the benefits, and are happy to go ahead with PSA testing. Couple of quick slides in terms of the current evidence for screening. So this is evidence that has been published since the NSC last did their review. So a couple of the big trials that we look towards are the ones on the slide there. So ERSPC, so that's currently a 16-year follow-up, and that's a screened versus not screened population trial. And that's showing a 20% relative risk reduction in prostate cancer specific mortality. So that shows promising signs, and that's something that we know a lot of European countries are sort of looking towards in terms of progressing their current policies on prostate cancer screening. The other one is the CAP trial. So that was a single PSA screening invite. And again, this is 15 years outcome data now. And that's only shown a small reduction in prostate cancer deaths. But I think it's important to mention that these trials do suffer from contamination. So you can have a trial population, but within the general population, you still have opportunistic testing going on. And again, they're both based on sort of PSA as the primary screening test, then biopsy, rather than PSA and MRI. So again, there's good evidence there, but there's still evidence that we can sort of try and build on. Just touching on the diagnostic pathway improvements that I've mentioned. So the old diagnostic pathway before MRI was, again, opportunistic testing, a rectal exam and blood test, then a biopsy, and then sort of diagnosis or ruling out of prostate cancer. Currently, blood test, MRI scan, and then MRI targeted biopsy for those men where the MRI scan shows that a biopsy is needed. I think up to a quarter of men avoid biopsy according to the evidence base, but actually in real world practice, that percentage is even higher. And then those that have a targeted biopsy go on to have, again, their diagnosis or ruling out. That pathway is much safer and much more accurate than the previous pathway. So again, consensus that because MRI is in the pathway, men who have a PSA over the referral threshold don't need to have a DRE. They can just be referred in straight from primary care. Further to our consensus, so although the harms of the diagnostic pathway haven't completely disappeared, our recent evidence shows that it has been, there's been a reduction, specifically in terms of the proportion of men who experience sepsis, and those that have to have, or those that are considered to have an unnecessary biopsy, so those that have an MRI or don't have an MRI, that go on to have a biopsy that they didn't need. So again, in this with this data, with this evidence, we're saying that prostate cancer diagnostic and treatment pathways have changed to make it safer and more accurate. So there still are evidence gaps, and that's where Transform comes in. Again, I'm not going to go into a lot of detail on this because it's not my area. This is the research team's area, and I'm sure they'll update in due course. But this is sort of currently what Transform aims to do. So it's looking to test 4 different arms in the first phase of the trial, first 3 years, and then the most promising of those arms will be taken on into the remainder of the trial. That trial protocol on the slide, that's currently in draft form still. It's undergoing sponsor review and ethics review, so it may change before the trial starts to recruit. But again, just on the side there, consensus statements that the research really needs to focus on these key areas of finding aggressive cancers that are being missed, further reduce the harms, and allow for better risk stratification. So in terms of informed choice, that's what current guidelines are based around. So we don't have screening, but we have an informed choice program, which is the PCRMP, Prostate Cancer Risk Management Program. So that guideline is based on UK NSC evidence reviews and what that evidence tells us at this point in time. So that guideline is what GPs should use to counsel men on the PSA test, and the benefits and the harms. But that guideline is reactive, so men have to know about it before they can go and ask their GP about it. And we know that men often come up against challenges and barriers when they want to go and speak to their GP about this. So again, consensus statement around this is that we need to change these guidelines because they are outdated, because it doesn't tell GPs what they should be doing for highest risk men. So we want them to be changed more, but obviously maintaining that access for all informed men over 50. Again, informed choice is about giving that balanced information, and it's all that information that's from the evidence base, and it's sort of how that's translated into language of messaging that men will understand. And then just in terms of how our consensus feeds into our awareness and activation, again, awareness should be raised. So that's what we do. And you'll all be aware of the awareness we do because you're part of that. But we do a lot of awareness through social media, posters on bus stops, in print media, wherever we have opportunities to maximize the exposure to this risk message, or these risk messages about 1 in 8 men and 1 in 4 black men, with the call to action of check your risk. And then that obviously brings people into our risk checker. And again, our risk checker, all the messaging and wording is based on what we've understood from the PSA consensus, who's at risk, who's at highest risk, where the strength of the recommendations are in terms of what men should be doing. And then just a few slides left in terms of tackling inequalities. So again, it's just reiterating that point around highest risk men, so black men, men with a family history. So these are the stats which you're probably all aware of. And more recently, in our latest media story, based on some national data, we're sort of saying that black men, or we're seeing that black men are more likely to be diagnosed at a later stage as well. So prostate cancer really in black men is a real big concern for us, and part of why we have these consensus statements to try and change GP's approach and change the guidelines. There's also geographic inequalities, so men from deprived areas, 29% more likely to be diagnosed with a late-stage prostate cancer. So again, part of our work is around getting those awareness messages into those key regions to get awareness up. And then there's a few issues that we know around barriers to action and sort of the things that we do around myth busting as well. So one key point on there is around the number of men or percentage of men that think that the first test for prostate cancer is having a finger up the bum. So again, addressing that that concern, but also that consensus statement alongside that for GPs around not needing to have the DRE. So just a quick summary. So prostate cancer screening is not currently recommended. There are limitations in terms of the PSA blood test on its own, and that's seen in the evidence base. But we know there's a shift in that in terms of PSA plus MRI. We're awaiting that update from the NSC following their evidence review. The evidence that we've built shows shift in harms and benefits, but some uncertainties remain, and hence the Transform trial. So in the meantime, we do have this PCRMP guideline, but we're pushing for updates to that alongside awareness activation, check your risk campaigns, tackling inequalities, providing that balanced information on the pros and cons to support informed choice. And then, using that PSA consensus to sort of drive that primary care education and guideline updates.